This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the European Journal of Trauma and Emergency Surgery, published in 2026. The title is Small Traumatic Intracranial Hemorrhages Identified in Routine Radiology Reports Are Associated with a Low Risk of Adverse Events, a Retrospective Cohort Study.
This is a topic that is near and dear to the heart of every neurosurgery resident and attending on call. We've all been there. It's 3 a.m. and you get a consult from the ER for a small intracranial hemorrhage found on a routine CT for a patient with a minor mechanism of injury.
Exactly, Dr. Aris. The study really dives into the clinical reality of these small TICHs. The authors focused specifically on hemorrhages that were identified in routine radiology reports. The core question they asked was, what is the actual risk of these patients experiencing a significant adverse event?
And in our field, adverse event is a heavy term. Usually we're talking about hematoma expansion, the need for neurosurgical intervention like a craniotomy or ICP monitor placement, or most drastically, neurological death. Ilara, what did the cohort look like in this study?
It was a retrospective cohort study, which is the gold standard for looking back at how these patients actually fare in a real-world setting. They looked at a large volume of patients who presented with traumatic brain injury, where the initial radiology report flagged a small hemorrhage. We're talking about small subdural hematomas, punctate contusions, or minimal traumatic subarachnoid hemorrhages.
One of the most important aspects of this paper is the phrase routine radiology reports. Often there's a discrepancy between what a general radiologist sees and what a neurosurgeon sees. But the study uses the initial report as the baseline because that is what triggers the neurosurgical consult in the first place.
Right, and the findings were quite striking. The study concluded that these small traumatic intracranial hemorrhages are associated with a very low risk of adverse events.
Low risk is a relative term in medicine, but for a neurosurgeon, it usually means we might be over-treating or over-monitoring these patients. Did the paper quantify what they meant by low risk?
It did. Across the cohort, the rate of neurosurgical intervention was remarkably low. Most of these patients did not require any surgical procedure. Furthermore, the incidence of significant hematoma expansion, the kind that actually changes clinical management or leads to a decline in the Glasgow Coma Scale, was also minimal.
That's a crucial point for the residents listening. We often admit these patients to the ICU or a high-acuity step-down unit for Q1-hour neurochecks. If the risk of expansion or intervention is truly as low as this study suggests, we have to ask ourselves, are we utilizing our resources effectively?
The authors actually touch on that. They suggest that when these small hemorrhages are identified and the patient is neurologically stable, the risk of a crash or a sudden need for the OR is almost negligible. This challenges the traditional dogma of automatic ICU admission for any TICH, regardless of size.
I want to dive deeper into the adverse events they tracked. Did they look at the timing of these events? In my experience, if a small bleed is going to blossom, it usually happens within the first 6 to 12 hours.
The study echoed that observation. The very few adverse events that did occur happened early. This reinforces the idea that if a patient remains stable through that initial window, the likelihood of a late-term deterioration from a small bleed identified on the first scan is incredibly low.
Let's talk about the clinical implications for a moment. For a practicing neurosurgeon at a level 1 trauma center, we see these constantly. If we follow the data from this 2026 paper, could we potentially manage these patients on a regular floor, or even discharge them with close follow-up if they meet certain criteria?
That's exactly where the authors are pointing. They argue that because these small TICHs in routine reports carry such a low risk, we could streamline our protocols. It could reduce unnecessary transfers from smaller hospitals to major trauma centers, which is a huge burden on the healthcare system and the families involved.
And for the medical students listening, it's important to remember that a positive CT scan doesn't always mean a surgical patient. Neurosurgery is just as much about knowing when not to operate and when not to over-monitor. This study provides the evidence-based backbone for that conservative approach.
Another interesting point in the paper was the focus on routine reports. The authors noted that small hemorrhages are being caught more frequently now because of the increased resolution of modern CT scanners. We're seeing things today that we might have missed 20 years ago.
Absolutely. We are essentially overdiagnosing tiny bleeds that may have no clinical significance. The study calls these associated with a low risk, which is a polite way of saying many of these might be incidental in the context of the trauma.
However, we should be careful. The study does specify that this applies to small hemorrhages. They aren't talking about a 10-millimeter subdural with midline shift. They are talking about the findings that often lead to the just-in-case consult.
Right. The stable GCS15 no focal deficit patient with a 2-millimeter sliver of SAH. According to this cohort, the risk of that patient needing me to open their head is nearly zero.
Exactly. And the paper emphasizes that the routine radiology report is a reliable enough indicator to begin risk stratifying these patients. If the radiologist calls it small and the patient looks good, the data says they'll likely stay good.
What were the limitations mentioned? Every retrospective study has them.
Of course. Being retrospective, it relies on the accuracy of past documentation and the consistency of the radiology reports. There's always a bit of variability in how different radiologists might define small or minimal, though the study tried to account for that by looking at the outcome regardless of the specific terminology used in the report.
It's a call for a paradigm shift, really. If I'm a resident and I see this study, I'm using it to justify a more relaxed monitoring protocol for the small TICH on my list.
And as a researcher, I see this as a foundation for prospective trials. If we can prove this prospectively, we could change the national guidelines for TBI management.
It also has massive implications for anticoagulation. Did the paper mention patients on blood thinners?
It did. While patients on anticoagulants are always at higher risk, even within that subgroup, if the initial bleed was small, as per the radiology report, the rate of catastrophic expansion was still lower than many clinicians fear, though they still require more caution than the general population.
That's a key nuance. A small bleed in a patient with an INR of 4.0 is a different beast than a small bleed in a healthy 20-year-old. But even so, the overall trend in this 2026 data points toward the benign nature of these small findings.
One final takeaway from the study was the cost effectiveness. By identifying these patients as low risk, hospitals could save thousands of dollars per patient by avoiding unnecessary ICU stays and repeat imaging.
It's about high-value care. We want to provide the best care without causing the financial toxicity of an unnecessary week in the hospital for a tiny spot on a CT that was never going to cause a problem.
Well said, Dr. Aris. This study from the European Journal of Trauma and Emergency Surgery is definitely going to be a reference point for our morning rounds.
It certainly will. To summarize for our listeners, small TICHs identified on routine radiology reports are associated with a very low risk of adverse events like expansion or surgery. If the patient is neurologically stable, we can breathe a little easier.
Thanks for joining us today on the Neurosurgery Hub podcast.
Stay sharp, and we'll see you in the OR.